Very good afternoon, friends. It's a very practical talks for this IC we have. We have eminent speakers and who are all been doing their glaucoma practice for quite some time. So it will be really useful for all of you that you can take some practical points from these talks and you can go back and practice yourself. So we know that lasers in glaucoma plays a major role in the management, in controlling our disease, the glaucoma disease. So first talk is going to be by myself. I'm Dr. Sathyan. I'm going to talk to you on YAG and the argon laser, but we don't have much of a role in argon laser, but mostly I'll be talking on the YAG laser. Whether you take argon or YAG, the indications are going to be whether it is a primary or secondary angle closure disease is one of the main indication for the laser. The second main indication is probably going to be the open angle glaucomas where you want to do the SLT or ALT, where you want the angle to be a little widened. That is one area where you can have the indication. Then in pigmentary glaucoma, though we know that the AC is deeper, but there is a rubbing of the iris. So when you do the PI, there is a posterior and anterior side. The equilibrium is maintained, so it is useful to do the PI. So these are all the indications. But what actually is the benefit of doing the PI is possibly we are reducing the risk of the acute angle closure disease in one. The second thing is may reduce the risk of a chronic angle closure disease. Can we say that once you do the PI, the patient will not develop an acute angle closure disease? It is not true. Very rarely, some may develop an acute angle closure glaucomas. There are some papers on that where the PI is possibly occluded. In those cases, you may have the attacks. So there are a few things which is very essential for us to understand is the safety and the precautions. Many a times we really don't ask the patients whether they have the bleeding disorders, or we don't really specifically ask this question. So it is better we understand that we go and specifically ask for any liver disease or any bleeding disorders they have, and also asking for them about their tablet aspirin, because it is very commonly been used by many of the people, especially those above the 35 or 40 years of age. So clopidogrel or the aspirin or any other heparin-related compounds, whether they are taking, it is better to ask. Taking the consent earlier days, even recently also, many of us, we really don't take the consent for YAG thinking that it is a very safe procedure. Of course, it is very safe, but once you have the bleeding, then we have the problem of facing the legal consequences. So these are the three triads, I would say, that very commonly having the problem as the IOP spike, post-laser IOP spikes. The visual dysphotopsias, how many times we really ask? We really don't ask unless the patient really complains. And the amount of corneal damage, which is probably is very negligible. Again, we are not looking much into that. So the pre-procedure, constricting the pupil to stretch the iris is critical. If you really don't constrict, it is well and good, it is fine. As long as you see the good crypt, it is not a must that every case has to be constricted people. You need to have. But if you don't want to use the pilocarp, in the post-pilocar effect, for the first 2 hours, the patient really have a severe headache, or they keep complaining about the dimness of vision for at least few hours. So you have to understand, probably you can give a paracetamol or whatever the tablet, or most of the time we try to convince the patient it will be just going off. If you don't want to put the pilocarp in, you still want to have a very small pupil, then you have to shine the torch in the opposite eye of other eye which you are doing, so that the pupil becomes smaller in this eye. It is a consensual. And once you shine a bright light in this eye, the eye which you want to do the laser PI automatically becomes smaller. So why you want to shine the other eye light is to make sure that it is a sustained constriction of the pupil. It is not light is enough for that particular eye. So consensual also works really well. So that's why you have to put the other eye torchlight and this eye bright light to the eye which you want to do the laser. So there are different machines. Most commonly used are the Zeiss and the Apasami machines. So I'll just discuss about a little bit on the very commonly used Apasami machine. how to use the laser. So switching on is the first thing, but Appasamy machine again comes with the two different modes. One is the SLT combined Appasamy YAG laser machine. One is without SLT machine. So there are two different machines. So make sure that SLT mode is switched off and you go with the only YAG mode. So that is the first step. And the second step is this is a SLT mode and then switch to YAG mode. So I want you to understand the Appasamy machine uses on the super Gaussian mode. The other Zeiss machine works on the Gaussian mode, the lasers. So the power settings, you cannot really step up like 1.1, 1.2 like that. You cannot step it up. It goes up to like 1, 2, 3. So you got to be a little bit careful because the power delivery is a little bit more higher than what you can use it with your Nidec or Zeiss machines. So this is the power settings. So you can adjust. This is the mode for the power setting mode. 1, 2, 3 we can adjust. Usually the power settings in the Zeiss machine is between 4 to 5 or 3 to 5 depending upon the iris thickness one can set. In Appasamy machine you usually go with the 2. That is more than enough. The 3 it will really blast the iris, so don't go with that. The aiming beam again. If you really look at the aiming beam in Appasamy machines, only 2 lights you have, 2 aiming beams. In Zeiss machine, you have 4 aiming beams. So focus all the aiming beams on the crypt so that it is focused exactly on that. So that is the aiming beam. How you really so once you increase the illumination, what happens is there is a blur effect. So you never go with a high aiming beam, so you will have more blur effect. So adequate intensity of aiming beam is good enough for you. Then you can use the laser. Experienced people, some people they don't use the lenses. I don't use the lens. If you have a very thin crypt, anything you want to ask? Any thin crypts, most of the time you don't really require, but if you have a thick iris, there is no crypt, it is better to use the lens, Abraham lens. There are different lenses. So just ask the patient to look up and then just insert the lens how you really insert your regular gonio lenses. That is good enough. The next thing is identifying the crypts becomes the mandatory thing. Once you have identified, where do you really identify the crypt is between the collarette and the peripheral iris. So this is the best area that you can do the PI. So the positioning of the PI is between the collarette and the peripheral iris. These are the areas, but I never advise you to go with the superior one. Earlier days we used to do the superior, but the dysphotopsia in the superior area is much more common. So the size of the PI, what you really require is only 50 micron thickness, but around 100 is a good size. But you don't have to really make it like a pupil size. Many of the people look at that as a pupillary size is good, but don't do that. I'm just making it little thing, but make it smaller. That is more than enough. Once you make really large, then you have to really expect that it is going to be, the zonal weakness is going to be there when you are doing your cataract surgery. So this is how you do, just focus it. 1 or 2 shots, usually it opens up when you have really identified the good crypt. So there's a gush of aqueous, and you can see the pigments getting released. Then you can see that PI is patent or not with the transillumination. Or today you can use the like Antirion and other machines. You can see whether it is really patent or not. Post laser, you can use prednisolone acetate, the drops. 4, 3, 2, 1, you can taper the dose and then you can stop it. Along with that, some of the times we do give the Diamox, but I have stopped giving the Diamox because we don't know which patient will develop the potassium depletion giving the Diamox. So we give topical beta blockers for 10 days time as a BD dose. Patients are much more comfortable, so you can, depending upon how you see that. The post-laser spikes has to be taken care. This is the post-laser follow-ups. You see after a day or you see after 24 hours, then 10 days follow-up. That is good enough. Most of the time we don't really look at any complications. These are the common complications which we face in YAG lasers. It is not that very uncommon. The commonest thing which you use when you are using the super Gaussian mode with the lasers is the transient microbleeds from the iris. So very commonly seen, the microhyphemas are very common seen in these YAG lasers. not in the Zeiss laser. That is where you have the advantage of using your argon laser. Argon laser will never bleed. When you feel there is a lot of inflammatory response, you still want to do the PI, it is best is to go with the argon PI, argon first, surrounding, and then the center you can do the YAG. That will be the perfect way that you can look at doing the PI in these cases. So as I mentioned, these photopsias are pretty common when you have it in the superior area. The other areas, the incidence of dysphotopsias are very, very less. So when you're planning for the cataract surgery in an angle closure disease, many times I would avoid doing a PI if it is going to be within the first 6 months that you are going to do the cataract surgery. Moment you do the cataract surgery, everything settles down. So you don't have to really rush and do the PI, because the moment you do the PI, especially the large PIs, there is going to be a synechiae. The pupils are going to be a little smaller. You are going to have a lot of troubles. Not in every case, but I try to avoid as much as possible. That is a practical way I can tell you. So doing a PI is pretty easy. It is not that difficult. Only the glaucoma people can do. Everybody can do the PI, provided that you take care of all your practical tips what I mentioned today. So thank you so much. We have other speakers talking about SLT and other stuffs. I request Moideen, before Moideen has his talk, is there any couple of questions we can have, or Murli, you can give your comments?
Yeah, thank you, Dr. Sathyan. I think understanding the need for the YAG laser and for knowing your machine before you do the laser is an extremely important aspect of the treatment itself. It's not just enough to be able to do a YAG laser iridotomy. You should know each patient is different, get a proper informed consent, know your machine well, know the parameters, know the settings. As the machine gets older, you will sometimes find that the same power which you were using a few years ago will not be working the same way. You may need a couple of sittings in certain patients because of the thick peripheral iris. Always do it. Choose a good crypt and constrict the pupil either with light or with a little bit of pilocarpine. And do it with caution. Don't assume that YAG PAs are very simple, and don't brush it aside as a casual affair. Give it importance. Patient has to be kept informed of the possible consequences. And then doing a gonio after the YAG PA particularly is very important to see what happens to the angle. And then continue to monitor the patient for the IOP and other aspects of glaucoma even after the laser is done. So laser is only the beginning of the sequence of treatment.
Yeah, thank you, Murli. And also we must know that when the laser head is getting empty, you go with a lot of empty shots. So we must understand when the laser head is getting empty, you have to ask the company to replace the laser head. So that is, again, very essential for us, because you may keep two in the board, but the laser may not be really delivering. A lot of shots will go empty. There are two things you have to understand. One is the laser head is getting empty, or the laser is not getting activated. So you just leave it for some time, again it gets activated, then you can do the laser again. So that's a very practical points which I have faced. Thank you. We have Dr. Mohideen from Arvind Eye Hospital, Tirunelveli. He is heading the department. And thank you, Mohideen, for accepting a very late invitation to you. So over to you, Mohideen.
Yeah, and the topic about organosis and suture laces, I thought we'll take it a little deeper. So we'll see early intervention following glaucoma filtering surgery. So a filter fail in 3 locations, either block at the internal ostium, or you make a tight scleral flap, or some subconjugal scarring. So I'll be talking only about tight flap closure. So risk of failure in glaucoma filtering surgery if you use of AGM for longer duration. You're not stopping before the surgery, at least a week, 10 days before surgery. If you're not practicing any use of preoperative topical steroids, the high risk of failure. Younger age group, previously unsuccessful surgery, a black rays, aphakia, pseudophakia, and neocytic glaucoma is a high risk for glaucoma filtering surgery failure. So management depend upon the cause. Do a digital massage, then you do an organosis suture lysis. Or if you're putting a releasable suture, release a releasable suture. And for a few minor injections and needling and blood revisions, repeat surgery and tube procedures. The laser suture lysis, why? Relatively effective. It will avoid early blood failure. The extra measure to control over the operation. So what the selectively raises subconjugal sutures as allows the postoperative tightness of intraocular pressure by increasing aqueous outflow. So ideally, to be done 7 to 14 days following a glaucoma filtering surgery. And if you're using mitomycin C, you can delay for more than 14 days. So what lens to use? Hoskin lens, no financial interest. The laser, you can use argon green blue, or you can use a double frequency Nd:YAG laser. The lens can be used Hoskin lens, easy to use. Hoskin has a blanches where you can blanch the congenital vessels, easy to visible the sutures. You can focus the suture, you can fix the globe. You can also use Zeiss 4 meter lenses, exactly the center point of it. You can use it for using a suture lysis. Other lenses can be a rich nylon sutures, or blue menthol lenses also can be used over the blood for lysing a suture. So this is a video. I just show you. The 2 weeks post-op with mitomycin C, we just cut one suture and the side suture. Apical sutures and the side sutures are intact. So once you do a suture lysis, look for spontaneous blood formation. If the blood is not forming spontaneously, then try to give a digital massage next to the blood. The force depend upon your experience, how much to give, and all depend upon your also pre-op assessment. So give a massage on the sides, on both sides, to elevate the blood. So you can see slowly the blood is elevating on the limbal side. So once you are happy with your blood elevation, then you can stop your suture lysis, and then you just give the patient steroids and just follow him up for next week and decide about you want to cut next suture or not. So the nice blood, as the patient look down, and also do a blood massage in a sit lamp, because you'll be doing a suture lysis and laser machine. And look for any AC complications, look for AC normal depth, any hyphema. All that you just look, and also you can look at the IOP. So bring the patient back to the sit lamp, do a massage, look the AC and look the IOP, then send the patient. So the power setting is you can use around 300 to 800 milliwatts. Make it a small spot size, 50 micron spot is very good because duration is 0.02 seconds. And technically don't cut more than one suture at a time, because we tend to do, sometimes we tend to do more cut. If you do cut more than one suture at a time, you will land up in a complication. So what are the complications? If you have subconjunctival hemorrhage, if you have fluorescent stained conjunctiva, it will absorb more laser energy. So try to use less laser energy, because it can cause a congenital perforation. It's safe to remove only one suture at a time. So what are the complications? Immediate post-op complication, wound dehiscence. Excessive manipulation of underlying conjunctiva to locate the suture can result in a conjunctival wound dehiscence, sometimes requires a surgical repair. Congenital perforation, I told you, when somebody has a subconjunctival hemorrhage, reduce your energy, somebody can have a hole formation. It heals in 24 hours time. A blood leak should be rolled out before performing an ocular massage. The other complication, hypotony, reportedly the most common complication. The incidence from 18 to 35%. So that's the reason you avoid vigorous massage and the laser machine itself. So bring the patient to the sit lamp, you see what happened to the blood, then you give a massage. So good patient education and usually resolves spontaneously. And flat chamber, they usually will respond to cycloplegic and also acute suppression and patching therapy, especially for angle of the glaucoma. We always take atropine with us whenever we do a suture lysis for angle glaucoma. After suture lysis, we put one drop of steroids and also put atropine immediately following suture lysis, especially for angle glaucoma. And also can conservative management with or without acute suppression, especially for external acute leak. Iris incision is possible. I had one case, still remember. A sudden decompression in the presence of small peripheral iridectomy can lead to iris incarceration into the ostium, requiring a surgical repair. Then you take it immediately, because you try to give too much of pressure, sometimes it happens. Hyphema, it happens, it results in 72 hours. Benign glaucoma, still possible due to sudden decompression following successful lysis. Answer is in 48 hours of the procedures. A risk factor persisting narrow angle with pre-op procedure high intraocular pressure. So anybody have very high intraocular pressure and narrow angle, you try to do a suture laser a little later. If you also use, don't stop atropine following, especially for angle glaucoma patients. So we have some European glaucoma guidelines. They say, consider focal person in case of poor filtration shortly after tuberculotomy, especially in your first week to 2 weeks, is a good measurement before doing a suture lysis. And how do you do it? You just give a massage next to your blood on the sides, or to your side. Look for the blood formation. How much blood is forming? How much time is taking? So you know which suture to lyse. Some people put some suture, tight suture on one particular suture. So you can lyse that particular suture to get your blood back. So It's done by a surgeon to assess your filtration and better to do before suture lysis. If you feel some bleb is forming immediately with the slightest massage, don't do suture lysis. So look for the bleb. And then also can early postoperative intraocular pressure predict the success of mitomycin C trabeculectomy in angle of the glaucoma. So this study says, so if the IUP on the day 1 is less than 10.5, or IUP on the day 7 is less than 13.5, the rated risk of failure was 4.2. So cutoff value of more than 13.5 on the day 7, which achieves accuracy of 80% the predicted success of IUP less than 15 without medication, and 50% for the predicted failure of more than 15 with the medication after surgery, respectively. So what the study says, a control of early IUP less than 13.5 millimeter mercury or less provide a better outcome. So immediate intervention after surgery has considerable role in maintaining filtering and change the probability of success following trabeculectomy. So take-home point is check IUP in day 1 possible, keep the IUP less than 10, and day 7 keep it less than 13.5, achieving a good filtering in the early postoperative period of trabeculectomy assesses the procedure of the long-term success. Thank you. So we don't want a bleb to be, we want something to be turned, diffuse, and posterior filtering bleb, which is a lower one. Thank you. Yeah, I think I'll have. The next presentation is about iridoplasty. I think just finished off.
How many of you do the suture lysis in every given patient of yours? Any of you are doing trabeculectomy here? Of course, there are few people here. So most of the time, it is very less likely we are doing it. But the common question, Moidin, is the common question asked is, we don't have an organ, can we do it with a YAG? So people mistake that the double frequency YAG as our regular YAG. So what is your advice? Have you ever tried doing a YAG laser?
I think you'll damage your lens. You cannot use a lens more than once. I think that's more. I think you'll damage your lens. The lens will get a crack if you use a double frequency. I never tried, but normally they say don't use it and crack your lens. Whatever lenses, contact lenses it uses for doing suture lysis can get cracked.
You're talking, yeah.
I think definitely it is not advisable to use the cutting laser for doing the suture. You must use a coagulating laser like argon or blue-green or the frequency double. Yeah. Like he says, I have also had the bad experience of cracking and pitting a lens when you do to the, don't do it. It's not worth the cost of a laser and the lens.
No, the common, because it's a very commonly asked question, can I use a YAG laser to cut the suture? It's a very commonly asked. So one is the lens damage, and what we need to understand is we need to use a laser which is a coagulating laser, not the photodisruptor. We have to use a photocoagulator when you are doing it. But if you can really cut without any lens damage, it is up to you, but it is not advisable. So we can go with your second talk.
The next talk about, thanks Sathyan for giving 2 talks in a short time. So we're talking about iridoplasty. So primary angle cause of glaucoma is a major cause of blindness in worldwide, particularly in our Indian population. So laser iridotomy is a widely accepted treatment for primary angle suspect, primary angle closure, and primary angle of glaucoma, with the aim of relieving pupillary block and reducing further trabecular damage. So what is occludable angle? When you cannot see a trabecular meshwork in 3 or 4 quadrant on a primary gaze, you call it occludable angle. So what is plateau iris configuration? The iris roots angulates forward from its insertion in the iridocorneal angle wall is called plateau iris configuration. When these people with the plateau configuration develop an angle closure and despite the presence of pattern iridotomy, then it's a plateau iris syndrome. So you can see a double hump pattern. They say it's a plateau iris syndrome. Mostly it is diagnosed post-PA. So some patient might develop acute angle glaucoma despite a pattern PA and may present with a raised IOP. Hence, laser peripheral iridoplasty done to prevent acute angle closure in a case of PACS and plateau iris syndrome after iridotomy. So what is the mechanism? So placing a long duration, low power, large spot size burns is the extreme periphery of the iris, which physically pull open the angle. So it anatomically alterations, it can flatten the iris and increase access to the aqueous to the trabecular meshwork. So iridoplasty is to open functioning close to antechamber angle. Argon laser burns operate in the peripheral iris. It causes contracts of the peripheral iris. So the laser light is converted to heat, which causes the contracts of the stromal collagen, which is primarily responsible for immediate anatomical change. Later alteration include proliferation of the fibroblast with the formation of a contracting membrane. So which are the indication? A plateau iris, which is the forward rotation of the ciliary body, microphthalmic and non-ophthalmic eyes crowding of the angle, UL epiphyseal syndrome, acute attack of acute angle glaucoma, where iridotomy is not possible, or iridotomy failed to open the antechamber angle, to flatten the peripheral iris to facilitate trabeculoplasty, a presence of peripheral antisynechiae after goniosynechialasis to flatten the peripheral iris. So what are the spot size from the European Glaucoma Society? The spot size around 200 to 500 spot size. The power is 200 to 400 and exposure around 0.3 to 0.6 seconds. Location, aim beams will be directed to the most peripheral part of the iris. Optimal reaction, visible contraction of the peripheral iris with the flattening of the iris curvature without a bubble formation or pigment release. You aim for 20 to 20 spots over 360 degrees, leaving 2 beams diameter between each spots and avoiding visible radial vessels. So you can also use a Goldman 3-mirror or a single-mirror Gonial lenses, which causes a laser beam to strike tangentially. Or you could also use a flat surface of Abraham lenses, which cause laser burn to apply directly through the peripheral cornea over the surface of the iris. If you use the Abraham lens, the spot size will be larger. The power will be lower. So preoperatively, you instill pilocarpine, also use topical alpha-2 agonist prior to the procedure and immediately after the procedure. And iridoplasty was performed under topical anesthesia, Abraham lens. You can use the pilocarpine at least 3 to 4 times before doing procedures. Laser beams are focused into the peripheral of the iris to close to the limbus as possible. Just see, use Abraham lens. The ideal endpoint is just a contraction of the peripheral iris, not for the pigment release, not for the air bubble formation. Just you need to do 360 degree. Sometimes we use 25 spots per quarter, and sometimes we do even 100 spots per eye. So main thing is the spot size will be larger spot size, and duration has to be longer durations. So this is little more energy, so it causes a lot of depigmentation both right and left of the patients. So postoperatively, you anti-inflammatory medications for the week. Sometimes you can use pilocarpine for some time, prevent some IOP effect, and gonioscopy you do when the patient come for the follow-up. So 20-24 spots over 360 degree, leaving approximately 2 spots diameter between each spots. The endpoint consists of a localized iris contraction of the treatment site of each laser applications. So do gonioscopy, applanation. If you have AIOCT, also you can use AIOCT following this procedure, pre and post following procedures. The complication can be elevation in intraocular pressure, transient iritis, focal atrophy, distortion of pupil, and corneal endothelial burn. So we published sometime back a study of efficacy of laser peripheral iridoplasty, the treatment of eyes with primary angle closure and plateau iris syndrome, which is unresponsive to laser PA using AIOCT as a tool. So here patients are diagnosed with PAC, plateau iris syndrome, who had undergone laser iridotomy earlier, unresponsive to the procedure was subject to iridoplasty. So we followed for the 1 year. So out of 252 eyes, we come to only 24 eyes did not show any improvement. So around 10% of the patients need this kind of a procedure. We did not show any improvement clinically, and the IOP, these patients showed tragically significant increase over 6 months, following a laser PA were taken for iridoplasty. So after analysis, 8 eyes of the patients were diagnosed as an plateau iris syndrome, whereas the 16 eyes are diagnosed as an PAC. So these patients are subject to iridoplasty. We change the IOP, antechamber parameters are documented. After 25 patients underwent iridoplasty procedures, And there are equal distribution male and female, and the age also between 40 and 39 years old, and 7 patients in the family history of glaucoma. And the main outcome measure was IOP, peripheral endosync, AIOC parameters. We done AIOC AOD 500 TISA and sclerosis per angle. A number of medication post-op. We found out AOD and TISA SS angle, they slightly increase post-iridoplasty compared to pre-iridoplasty. This indicates angles are getting open. And also, if you look at the IOP pre and post iridoplasty, there are 24 millimeter pre iridoplasty and 16.5 millimeter post iridoplasty. So, iridoplasty seems to be a safe and effective technique for treating patients who do not show improvement either clinically or in anti-sample parameters after iridotomy. So, there are no major complications in the study. The 5 A's, 20% showed a transient IOP spike, which was managed conservatively. 1 head showed a persistent uveitis, which is also considered managementally, and 1 head had developed transient atonic people, which recovered without any intervention. So to conclude, iridoplasty is very effective in patients with PAC and plateau iris syndrome who do not show any improvement after an iridotomy. Thank you.
Thank you, Maidin, for covering up both the topics in a very excellent way, because it is not a very commonly done procedure. Having said that, the problem is how many times we really identify the patients having the plateau iris syndrome.
I think 10% of the population has a plateau iris syndrome. Only thing is we need to diagnose them.
That is exactly I'm asking. Because we really don't diagnose that often, though we know that it is very common to see the plateau iris configuration and the syndrome. The simple reason is the gonioscopy.
Yeah.
Yes, sir.
Sir, why do you put pilocarpine after doing iridoplasty for 7 days? Because pilocarpine will constrict the pupil. It will have the same role as you propose with iridoplasty, constricting the pupil, trying to reduce the narrowness of the angle of the anterior.
I normally put for a month and stop it. Normally put for a month, hatches at night. For a month post iridoplasty, that's my practice. There's no need to use pilocarpine. Once you do iridoplasty, no need to use.
Other way around, in these cases, did you try pilocarpine first before submitting them to iridoplasty? Because pilocarpine has yet not lost its clinical relevance, I can tell you, from my clinical experience.
Sir, I will just take up that question now.
Sure.
The simple reason is we know that we cannot use the pilocarpine for a very long period. That is one thing. If you really look at the plateau iris syndrome, it is not that the pilocarpine is going to be that effective also. It is not that it is not going to be effective at all, but it is not that. So when you are using it for a very long period of time, pilocarpine has its own effect on the lens and the peripheral lens iris diaphragm, which moves upwards, causing more of a synechial formation. So the role of iridoplasty is completely different.
Not for a long period, just for a while, and trying to see its effect before planning iridoplasty.
Yeah, you can do it. There's no problem.
That can be done, but at the same time, when you are looking at the pilocarpine versus directly on the laser iridoplasty, both has its completely a different role. Iridoplasty is for a long term, and the pilocarpine therapy, we really may not be able to use it for long term because of various reasons which you are aware of. So both are two different things, but though the procedure is there, how many of us really do the procedure is a questionable thing, because it is, I don't remember I'm doing nowadays, but I've done long time ago, the iridoplasty.
I think post PA, if you do gonioscopy, spend some gonioscopy, and then you can pick it up. It will be there. It is there. One thing we're not picking up. I think with the AIOC, we're picking up more cases of plateau iris nowadays.
Yeah. Dr. Parthasarathi, I have a question for you. You said PI at 12 o'clock, 3 o'clock, 9 o'clock, or 6 o'clock.
12, I said it is better to be avoided. 3, 9,
which one?
The lower half is better. The superior PI, I don't advise.
Is there any added effect of gravitation if you do PI at 6 o'clock?
It is not for the gravitation. It is basically to avoid the dysphotopsias when you do it in the superior part.
Okay.
Earlier days, we used to think once the lid covers the superior part, the dysphotopsias are lesser. That is our thought process. But it is the other way around. The superior PIs have more dysphotopsias in comparison to the inferior or temporal or the nasal PIs. That is the reason why I said better not to do the superior PI, which is very commonly done procedure.
And how many cases of diplopia you have seen after doing PI in your long practice?
I won't say no, but I don't have the exact numbers because that numbers are very less. Because I do a very small PI, I don't do the PI much bigger. But once you do a little larger PIs, the superior part, definitely the dysphotopsias are pretty common.
That's true. Thank you.
Thank you.
There has been a going forward in the same question which you asked about dysphotopsia and the need to do trying to avoid the PA in the superior part. The dysphotopsia seems to result from doing the arc laser or iridotomy along the tear meniscus line. The tear meniscus line in the superior along the eyelid. So that's what the one paper published showed, that the tear meniscus.
That was the paper which I showed you in the
So
presentation.
that is what seems to be more significant. Rather than some patients are complaining, some patients are very alert, and they do notice the dysphotopsia. The average patient does not notice it. If you ask for it and look for it, probably you will get it. You will see it.
Okay, we'll have the discussion again. Thank you, Moidin. I think Moidin has to go for his second talk in some other hall. So I would request Dr. Vijay to give a talk on the SLT versus ALT. Over to you, Vijay. There's an interchange of Dr. Prasanna will talk on micropulse, and Vijay is going to talk to us on SLT and ALT.
No, not this one. The other presentation. Not this one. Vijay Kumar, PPTX. Yes. Good afternoon. At the outset, I would like to thank Dr. Sathyan sir and Dr. Prasanna Venkatesh for giving me this opportunity. My topic is SLT versus ALT, reigning monarchs of open angle glaucoma. The agenda of the talk is to talk about laser trabeculoplasty, especially on selective laser trabeculoplasty, which is currently used, and argon laser trabeculoplasty, which is seldom used now, and a comparison between the two. Laser trabeculoplasty involves delivery of laser to the trabecular meshwork, which results in either mechanical or biochemical changes at trabecular meshwork, resulting in improved outflow, resulting in reduced IOP. It is primarily used in cases where maximum medical therapy cannot control intraocular pressures to target level, or the glaucoma is not that advanced. It's primarily used in patients who are non-compliant with the medication or have inability to apply medication, either because of aging, poor vision, or tremors, and also to decrease the load of topical medications which are used. There are two theories behind laser trabeculoplasty. One is mechanical theory, which shows that there is shrinkage of collagen material in the trabecular meshwork, resulting in constriction of the pores, opening up of pores because of constriction of trabecular meshwork, and improved outflow. The biochemical theory states that there is inflammatory expression of interleukins and TNF-alpha, resulting in activation of macrophages, which clearing up of debris at the trabecular meshwork pores and improved outflow. There are two types of laser trabeculoplasties. One is selective and another is argon laser trabeculoplasty. The selective laser trabeculoplasty has the principle of selective photothermolysis, which relies on selective absorption of short laser pulse. It is primarily indicated in all open-angle glaucomas and previously failed argon laser trabeculoplasty, PXF and pigmentary glaucomas, and potential use in steroid-induced glaucoma has also been tried. ND-arc laser of 532 nanometer, frequency doubled, Q switched laser, spot size is 400 microns. This duration is 3 nanoseconds. The energy used is very minimal, that is 0.4 to 1.2 millijoules. It is applied either 180 degree or 360 degrees of the trabecular meshwork. Move faster, move sir. Yes, so slides are moving faster. Yes, sir. Yes, sir. Just moving 2-3 slides ahead. Oh, no, press one. When I press one, it goes to 2 slides. This is better. Okay. Okay, thank you. So the energy level when we start the procedure is kept at lowest at 0.8 millijoules, and a test pulse is delivered to the trabecular meshwork. The surgeon is able to visualize a bubble formation. The pulse energy is gradually decreased by 0.1 millijoules at intervals until a minimal bubble formation is detected, and a suitable pulse energy is then determined, and the treatment proceeds. Recommended protocol are always in a flux, and it is started at 180 degrees inferiorly at 50 spots, 25 spots per quadrant, and in severe cases we can try 360 degrees with 100 spots evenly spaced over the trabecular meshwork. The pressure lowering effect is improved if all the 360 degree of trabecular meshwork is treated. There is an alteration in SLT protocol in case of pigmentary glaucomas. It is considered an exception in treatment with laser trabeculoplasty. The SLT energy is absorbed more in pigmentary glaucomas, which results in dispersion into the AC, and intraocular pressure spikes are noticed. So, in case of pigmentary glaucomas, only 90 degrees are treated at a sitting with minimal energy with no bubble formation. Outcomes include 2/3 of the patients will achieve a reasonable intraocular pressure fall within 6 months. Ocular hypertension and early glaucoma have shown 80% drop in medication-free period, and also the target pressure is maintained for up to 3 years. The effects are generally wane over time. Treatment can be repeated with a successful outcome. Even if the initial treatment is failure, we can still continue a second treatment. The common adverse effects include mild inflammatory and mild discomfort for the patient. There is primary peripheral anterior formation and intraocular pressure elevation has been noted, but usually the IOP spikes are very mild. Substantial rises have been reported in heavily pigmented pigmentary glaucomas, which are overtreated with extensive energy. In extensive treated areas, the damage to corneal endothelial cells has also been reported with endothelial decompensation. Reactivation of herpes simplex keratitis and a few cases of macular edema has also been reported. The primary contraindications include the cases where there is hazy media and poor visualization of trabecular meshwork and closure of iridocorneal angle and corneal edema, and inflammatory glaucomas like uveitic glaucoma and juvenile glaucoma. Patients with age less than 35 years are not considered for this treatment. Argon laser trabeculoplasty, it also uses laser burns to achieve intraocular pressure reduction compatible to SLT. The primary indications are very similar to SLT, which are primary and secondary open angle glaucomas, ocular hypertension, and failure to adherence to medical regimen adjunct to avoid polypharmacy. The mechanisms overlap with SLT with both mechanical and biochemical changes resulting in improved outflow. But in case of ALT, there are more thermal damage to the trabecular meshwork, hence the repeat treatments are generally avoided. In ALT, we use argon laser of 488 to 540 nanometers. Spot size is larger compared to SLT, which is 50 microns. The duration is also longer, 0.1 second. And the energy used is also more, 30 to 90 millijoules of energy. And at a sitting, we only treat 180 degrees. The procedure of ALT, wherein we aim the beam at junction between pigment and non-pigment epithelium. Optimal reaction is a slight blanching. So procedure is, we give 50 burns regularly spaced 180 degrees, 25 shots per quadrant. Post laser, the patient is started on fluoromethalone or prednisolone eye drops 4 times a day for a week. Medical glaucoma therapy is generally continued till we achieve the intraocular pressures at the desired level. The follow-up is dependent on the perceived level of risk. Complications are very similar to SLT, but slightly more because of the increased thermal damage. Peripheral anterior case has been noted, acute elevation of intraocular pressures, cystoid macular edema, and anterior uveitis because of inflammatory thermal damage. Efficacy is very similar to SLT. There is 30% reduction in average intraocular pressure in primary open angle glaucomas. 50% of the eyes remain well controlled up to 5 years of treatment. Significant scarring has resulted in reuse of ALT has never been tried. Laser parameters, comparison between ALT and SLT. The spot size is larger in case of SLT, and in ALT it is smaller of 50 microns. Number of spots are same, 25 spots per quadrant, equally spaced. And energy used is 500 milliwatt in argon laser trabeculoplasty, whereas it's less than 1% of ALT in SLT. Exposure time is also very minimal in SLT, and there is no thermal damage in SLT. This is a comparison of spot size between SLT and ALT, where you can see the largest spots in SLT of 400 microns. In case of ALT, it is 50 microns. And this shows the thermal damage resulting in coagulative damage of the absorption of thermal energy at the trabecular meshwork noticed in ALT, where in SLT, the trabecular meshwork architecture is maintained. The intraocular pressure efficacy of both the lasers are comparable, but the advantage of SLT, it is repeatable. Rate of complication is also slightly lower in case of SLT compared to ALT. Prognosis, either form of laser trabeculoplasty, actually the effect wanes over time, but both are equally effective. But in case of ALT, since there is no repeat treatment possible, SLT is advised. Advantage of SLT over ALT is it causes lesser damage to the trabecular meshwork, fewer adverse effects. And IOP lowering effects are very similar to ALT, but in SLT it's slightly longer. Repeatability is possible in SLT, but it is not possible in ALT. So, though laser trabeculoplasty is a drying treatment form, there are several advantages attached to laser trabeculoplasty. This reinforces the need to bring in a larger scale implementation, usage of this excellent therapeutic option as efficacious alternative. Thank you.
Thank you, Vijay. I accept your last but one slide. We are quite optimistic about our SLT treatment. We all still do the SLT. It is not that SLT is not effective. SLT is quite effective, provided that you understand the angle anatomy properly. Quite a good number of them, they did say that the SLT doesn't work. The simple reason is when you do the SLT on the pigmented Swalby's line, it will not work. When you really do the SLT on the trabecular meshwork, the pigmented trabecular meshwork, it does work. The confusion for many of them is the angle anatomy. If you really can't understand the angle anatomy, then the SLT doesn't work. In primary open angle glaucoma, when the eye is a virgin eye, then the SLT really works. And there are controversies on what is the power settings. The power settings say, for example, you have the bubble formation, then you reduce 0.1, which doesn't work. When you have the bubble formation, it is better you keep seeing the bubble formation throughout rather than just reducing it. The moment you reduce it, in our hands it doesn't work when you reduce the power from that level. So for some reason, the imported SLT machines which I have is not that effective in comparison to the local machines. Like I don't know whether I can name the brand. Appasamy machine works much better for me in the SLT. We have the SLT and the ALT in the same machine, not ALT, SLT and the YAG-PI.
Yeah.
So that machine really works perfectly as long as you can do it on the trabecular meshwork with a good power settings. So it is not that we have just written off that SLT doesn't work. It still works. It has a role to play, especially when you want to add second or third medication. It really has a role to play. So we'll have the more discussions after another 2 more talks are there. Over to Dr. Murli. Murli, we don't need any introduction. He's one of the very well-known glaucoma specialists from Chennai. He's going to talk to us on the diode CPC.
Thank you, Dr. Sathyan, and I think it's a very nice symposium on his course on the various aspects of lasers and different situations where different types of lasers can be applied. I'm going to speak briefly on the diode cyclophotocoagulation. By definition, a difficult glaucoma, if we look at what we call it, we always call it refractory glaucoma. So I was wondering what the word actually refractory means in a medical sense. It means that difficult to treat or cure. So many patients, we have to impress upon the fact that we're dealing with a difficult glaucoma, and the glaucomas can be managed in many ways. There are more than one option, and diode is one of the options. So coming back to what is refractory glaucoma, raised intraocular pressure, painful blind eyes, failure of other glaucoma procedures, post-trap, post-tube, post-keratoplasty glaucomas, post-VIA surgery, silicon oil, other types of VIA surgeries, glaucoma and aphakia, congenital glaucoma unresponsive to the standard therapies, and of course injuries and multiple complex eye problems in which IOP remains high and you can't really do a filtering surgery. So what are the treatment options do we have? You have a refractory glaucoma and you want to know what to do with it. I think we've been discussing in the previous instruction course, discussed about increasing the medication to maximum available medication. So 5 medicines, 6 medicines, 2-3 bottles and so on. Consider needling, considering retrap, considering even a mixed procedure, GAD procedures to go into the angle instead of avoiding conjunctival surgery and so on. You have the glaucoma drainage devices, and you also have the method of destroying the ciliary body. So maximum meds, needling, retrap, give everything a chance before you go into cyclodestruction. Consider a retrap, MIGS and GAD procedure sometimes do well when nothing else is going to work. So among the glaucoma drainage devices, you have many available in India today. You of course have the Ahmed valves. You also have the Indian modification of the Bayer valve, the RD, which is also a very good non-valve device. You also have the Ahmed ClearPath 250 and 350, which is 250 is what we get most often. And we all await the introduction of the Paul glaucoma implant with the narrow tube, narrow inlet into the device, and the PGA is not yet available, but we await the. But what happens if you do an AGV? What happens if you do a glaucoma drainage device? This paper I found looked at the 5-year long-term outcomes, and it does quite well. Most of our patients do quite well, and we look at our own patients over the last 8 years, 10 years, and so on. This is a published series of IOP maintaining itself in more than half the patients who had the glaucoma drainage device. Cyclodestruction is to reduce the intraocular pressure by destroying the ciliary process located in the pars placata region of the ciliary body. But it is not the procedure of first choice for any kind of glaucoma generally, and was reserved as a last option for uncontrolled glaucomas in patients with poor vision potential. But we are now considering it as a limited diode, and even the micropulse is being considered for patients with seeing eyes. So in the past, we had procedures like cyclodiathermy, beta radiation, and for those of you who are studying and fellowship and students, I think this is of interest. Cycloelectrolysis, even microwave was used to destroy the ciliary body, and some all animal studies, nothing really went into clinical practice. Cryotherapy was used for a very long time. We've all done cryotherapy for many, many years before switching on to the lasers. And certain centers, the high-intensity focused ultrasound is also available, but is not commonly used in many centers. You can also deliver the energy through the transcleral route by contact method, transpupillary non-contact, and also deliver it intraocular by endoscopic methods. So historically, the xenon arc, the ruby laser, and the Nd:YAG laser have been tried, and the krypton laser also was tried for cyclophotocoagulation. But the semiconductor diode of 8-10 nanometers has become the most commonly used procedure today, after American Academy's technical report recommendation that it has lesser energy, better absorption by the uveal melanin, quicker, durable, and also portable and lower maintenance costs. I think my own diode laser is now with me for about 18 years, and I still keep using it. I've only been changing the probes. Of course, the periodic service. The mechanism by which the IOP reduces is reduced aqueous production, destroying the ciliary epithelium and reduced vascular perfusion, and also maybe an increased aqueous outflow past plana or transcleral cyclo kind of an outflow. So that is also a possible hypothesis or mechanism by which the IOP gets lowered. If you look at the Cochrane review, which looked at a lot of papers and kind of analysis of many, many published articles on the cyclodestructive procedures for refractory glaucoma, the evidence actually was not conclusive as to whether one procedure is better than the other. But what was very clear was that the common side effects were there: hypotony, phthisis bulbi. And what was not reported commonly was the patient's pain, quality of life. And these, I think, should be study and important, or what we should say, parameters to be measured as outcomes in future trials. But whether one type of cyclodestructive procedure is better than the other is not very clear after this Cochrane review. So we have left our own choices as to what we can offer to a patient, whether we want to do a reprocedure, whether we want to do a glaucoma drainage device, whether we want to consider a limited diode and so on. So I have been using the transscleral diode laser with the G probe for many, many years now, more than a decade. And the G probe, as it is called, it's a fiber optic tip, 1.5 mm, it protrudes, and behind the kept 1.5 mm behind the anterior edge of the foot plate and protrudes about 0.7 millimeters. The tip is a little bulge in the foot plate. And the general settings, this is some of the standard settings. About 1500, 1800 power, about 2000 is the milliseconds, and then you can keep it in repeat mode if you want and keep doing the laser. Generally, we do not do 360 degrees. We always end up with 180 degrees. Very, very rarely I have done 270. Always give a peribulbar block or a local anesthetic block, have a monitoring of the patient, and informed consent is extremely important, and it is done with all the precautions of how you do a surgery because you have given the block. It's a continuous wave energy delivered to the ciliary body by a laser probe kept about 1.2 millimeters behind the limbus. The G probe is the name of the device. I think there are other companies which make the same device, but the one I am using is called the G probe. 2000 watts for 2 seconds is actually maximal. And if you hear the pop, an audible pop is sometimes heard. This actually pop is a micro explosion or the ciliary process. Once that happens, you obviously know the energy is too much. You scale down the energy and start using lesser energy. And do not treat, again, as I already said, do not treat more than 180 degrees in one session. You're going to have risk the chance of hypertony and phthisis. Very high incidence can be there. Post-operatively, you need to give cycloplegics, you need to give some systemic analgesics for comfort. Steroids, yes. I sometimes continue glaucoma medication, but a little less number of glaucoma medications, but don't stop all the glaucoma medication. My favorite is to go brimonidine timolol combination, and I stop the pilocarpine and prostaglandin if the patient has been using it preoperatively. Transient IOP is common. Pain, uveitis, hyphema, hypotony, choroidal detachment, phthisis. You should be prepared for any complication which you may be surprised by seeing it the next day. Be prepared, maybe an hour later, evaluate the patient. Evaluate the patient the next day to the extent possible, as far as possible, and then keep following up the patient closely. And you will sometimes find in children, juveniles, and certain types of eyes with distorted anatomy of the ciliary body and the limbus, you will find it's difficult to locate the ciliary body. Routinely doing it 1.2 millimeters behind the limbus is not correct. You should actually transilluminate, and there are many papers which will tell you the ciliary body position as identified by transscleral or transcorneal transillumination will tell you the dark area of where the ciliary body could be. So treat the ciliary body and don't just blindly treat 1.2 mm behind the limbus. Intraocular endoscopic CPC is another option, and this is actually directly visualizing with a single probe which you can actually look into the eye, look at the ciliary process and directly pop off the ciliary process one by one wherever you want to see it. Aphakia, pseudophakia, it has to be vitrectomized, and a limbal or pars plana route is also possible. Visualize it. And the ECP probe made by a certain company actually is an expensive machine, combines a diode endolaser, an aiming beam, a light source, an endoscope into one single probe. The single probe, which has all of this into one single probe, allows for a targeted, controlled ablation of the ciliary process, direct visualization, and titration of the power. Can be combined, the ECP can be combined with phacoemulsification surgery. There are many publications on this. The reports of IOP reduction range from 2 to even up to 10 millimeters of mercury with ECP alone, and a much higher with the cataract surgery is combined with the ECP. This is actually a meta-analysis, a paper which looked at the differences between the aquashunt and the ECP. And if we look at this particular paper, it really showed that between ECP and the aquashunt, there's not really too much of difference. Provided, of course, you have the device and you're combining it with the cataract surgery, and of course, you have the luxury of having a retinal surgeon who can actually handle the probe. The micropulse, I think Dr. Prasanna is going to speak about the micropulse. Now I have switched to the micropulse diode laser now, and I think he's going to talk more about that. The histopathology of what has been published very clearly shows that the extent of severe damage which you used to see with the continuous wave is not seen with the micropulse. So I think it's a clear advantage. This is the way I do the micropulse. And the take-home message, Prasanna will talk more about the micropulse laser. The diode CPC is an option for refractory glaucoma. The continuous wave TSCPC ECP is reserved for non-seeing eyes. Phaco ECP is a good option in certain situations, and the micropulse is probably the way forward and in seeing eyes. But mind you, the bottom line literally is that cyclodestruction is not a primary procedure of choice for glaucomas. Don't offer it primarily to any glaucoma patient. Thank you for your attention.
We'll take up questions after Prasanna's talk.
Can I have the slides?
We have Dr. Prasanna Venkatesh from Tiruchi. He will be presenting on micropulse lasers.
AV team, can I have my slides? Yeah. Is the AV team there? Yeah, thank you. Yeah, so we'll have a quick slide-based discussion on micropulse. So I have no financial disclosures, and these are two of our cases. So you can see one is a right angle, primary angle closure, moderate stage, patient on 3 glaucoma medications and tablet Dimox, 0.7 cupping and 42. We'll come back to this, and this is again another patient on maximum medical therapy, IOP of 42. So let us come back to these cases in the end after the micropulse discussion, as Murli sir rightly pointed out, how we can have the micropulse for seeing eyes. So these are the objectives that I'll be covering in this talk. So obviously, as sir covered in his talk, traditional CPC destroys the ciliary body and decreases aqueous production, and it is an indication for refractory glaucoma. And now we are moving towards other procedures. Like when we use a continuous wave, as you can see in this video, there is so much of pigment dispersion, there is so much of pupil getting shrinkage, right? The thermal energy you can see in this arrow that I am pointing out. See how much the pupil is actually getting drawn towards that thermal energy. So we were doing a lot of pigment dispersion, atrophic bulbae or phthisis bulbae, and it was like a bullet in one of these kind of, in this particular video, as you can see on the left hand side. So how much of pigment dispersed like a bullet, right? So a lot of these can be avoided, and complications like hypotony, macular edema, is it really worth it? So the urge led to a rediscovery rather, where there was, so where there is a resurfacing of the micropulse that came from the 810 nanometer diode, which was used for the retinal lasers. Similarly, now you can see versus the micropulse for the retinal lasers, how the spots are very sub-threshold. So sub-visible threshold treatment was happening in retina, and that is something that we used for the glaucoma as well, whereas we minimize the thermal damage, and the continuous waves are actually broken up into a micropulse. So just like the phacoemulsification duty cycle, where we have the on phase and the off phase, right? Similarly, the continuous waves were broke into micropulses. As you can see on the bottom, I placed the continuous wave. Pulse is on for only 0.5 milliseconds, and it is off for another 1.1 milliseconds. So that's what micropulse brought into the picture. And I think I'm having some connectivity issues. Yeah.
Don't touch the table.
Yeah, I'm trying my best to not touch the table. Yeah, so there is an MP3 probe compared to the G probe that happens with the traditional CPC. So with the MP3 probe, you can see that now we have the bunny probes, but talks are going on and the companies are trying to give us the previous probes, which was slightly different to this bunny-eared probes that we have. And you have to use a coupling fluid because the coupling fluid prevents energy loss. We need to avoid energy loss, and the procedure operates on 2000 milliwatts. Some people prefer 2500 milliwatts or 2000 milliwatts, and 80 to 90 seconds, 1 eye per setting is the way forward with peribulbar anesthesia, which is quite common. You can also use a vasoconstrictor eye drops and avoid viewing on 3 o'clock and 9 o'clock position. The concept of duty cycle is very important. We had the on and off cycle, and as I told, it's a sweep movement that you need to do, avoiding the 3 o'clock and 9 o'clock position, and it is a ease of use. The learning curve is actually very minimal, and 1 or 2 sittings in a wet lab and you can easily go in and start it. And you can use always a toric marker to mark the patient to avoid the 3 and 9 o'clock, because there is some amount of cyclotorsion from the sitting and to the supine position which may happen, and you may inadvertently treat the 3 or 9 o'clock position. So this is my favorite one, the mechanism of action. So this is what the mechanism of action is all about. I've just simplified it to know how the machine works so that you can titrate the machine according to you when you are able to see that the results are not working the way it has to. The circumference of the eye is 52.9 millimeters, and we have 12 clock hours. So we have 12 clock hours. So 10 clock hours are treated, 2 clock hours are not treated. And in the 10 clock hours, if you see, 1 clock hour is 4.41 millimeters because the total eye is 52.9 millimeters. So we are going to treat only 10 clock hours. So we are going to have a path length of only 44.1 millimeter. The probe diameter is 700 micrometers. So if the 700 micrometer probe is going to traverse a path of 44.1 millimeter, this is what we get. 44.1 divided by 700 micrometer, that comes to 63 probe locations. So exactly 63 probe locations are the one that we are going to traverse, and it goes to physics, right? Energy is equal to 2000 milliwatts, rather the power into duration, that is 60 in the inferior quadrant, 60 in the superior quadrant, and the duty cycle of 31.3. We saw the on and off. So a cumulative energy of 100.16 energies are what we are targeting. And if you are going to treat 63 probe locations, then for one probe location, the energy that is going to be dissipated is 1.57 joules. Why it is important is in the next slide. So at 2000 milliwatts, you get at 1.57 joules. So what happens at 1.57 joules is, this is the video, my dear friends. You can see that there is a small amount of movement, but it's enough to actually cause the movement in the trabecular meshwork as well, or a cytoskeletal remodeling that going to happen after you have done this procedure. So what happens when you increase the energy? See, at 1.57, why 1.57 or why 2000 milliwatts is, it is at that point you will get the trabecular meshwork motion movement. If you have it less than 1.57, rather 1.25 or 0.9, there is no red graph at all. That means there is no movement of the trabecular meshwork. And why not more than 1.57 or rather not more than 2000 milliwatts is, if you move it more, or rather if you are increasing the energy more, the tissue recovery doesn't happen. Whereas with red, you can see that there is 100% tissue will actually recover. But with the other one, right, 2.35, or if you are going to use more energy, the tissue recovery won't happen compared to the 1.57 where the tissue recovery happens. This is another example of more energy. If you are going to use more energy, look how much the movement is. The movement is more exaggerated and the tissue may not recover, and it will move towards a continuous wave mode. Whereas if you use very low energy like a 0.08, you can see that even in a microscopic level, the movement is not expected, and even in zooming it even more, you can see that it's only a very microscopic movement which is not enough to cause the action to take place. So right, coming back to the hemisphere or quadrant, it's up to you. You can be an hemispheric approach person or a quadrantic approach person, that's your choice. Post-operative, it's more like what you do with a cataract, a topical steroid. A cycloplegics is very important, and glaucoma medication should not be discontinued immediately. That is something that is very important. And slowly taper your medicines if the IOP is going less than 10, and gauge it accordingly and then do the tapering. And retreatment can always be done, but not less than 6 to 8 weeks. That is something which is very important. So once you understand the physics behind it, that's why I broke up the mathematics and gave it, those are my own slides, where you can see that at the end of the day, you're using the same energy. 1200 to 1500 for a continuous wave is almost equivalent to this, but you end up having lesser complications. You can see that again, energy is graph I've given you, 120 joules in a continuous wave compared to 126 joules that you are using in a micropulse, less pain, less inflammation, and almost near minimal complications as possible. We try to maximum to avoid moving into the redder zone. When you move more into the red zone, that is by increasing the 2000 milliwatts to 2500. If you feel the patient demands it, then you will be moving more towards the continuous wave. Care has to be kept in mind that we'll have to hit the green zone. Sometimes different patients may have different green zones. Maybe we need an additional sweep, or maybe slightly titrating your energy from 2000 to 250 or 2500 milliwatts. Always retreatment is favorable because it's a favorable safety profile and it's a non-incisional procedure. So we started with cases like these: avoid blebs, avoid scleral patch graft areas, and these were some of our initial data that we started in 2018, 2019. When we started slow and steady because we didn't know how to go about it. These are some of the data. We started with only one hemisphere. Then slowly we moved into 2 hemispheres. And the IOP drop is very good. It's up to 30 to 35%. And there are many pearls, like the secondary glaucomas you can take into consideration. And I'll not go into the details of it. The IOP reduction and the success rates are very promising, and clinical evidence shows it's safe, durable, and versatile. This is something which is very debatable, primary, or is it too early to say? Studies are showing that patients who are having visual outcome, good vision, as Sir pointed out in his last slide, if this is the only procedure that is safe, I think we can go ahead and start with this as well. But we need to know the fair share of complications that is reported, drop in visual acuity. We have seen patients with cystoid macular edema, and these are some of the ones that are published in literature as well. So the journals are also saying that the human equation is one that is something that we need to master, because there is no audible cue, and the mechanism of IOP reduction is not very convincing. It's not foolproof. So we need to be more concerned about the human equation. Sometimes we need to know what works best in our hands, and this is not the only solution. This is something that is there along with the other things. Yeah, and there are many studies which says that there is a lot of efficiency, and I would like to point one study by Murli Ariga sir et al., and he's also coming up with another paper with a new probe, 89.1% surgical success at 3 months, and AGM reduction of 2.8 from 3 to 2. So that's a significant number. Dr. Sathyan sir has also come out with another one of his own. And coming back to the first slide that I showed, so this is the first patient where the patient was treated, and the patient had a spike after 3 months, and then we had to go ahead and do a trabeculectomy. And this is the second patient where the patient's IOP was brought to 24, and after 1 month again a combined surgery. So this is one procedure we feel that it is something that is going to be more like working for refractory glaucomas or secondary glaucomas. You can bring down the pressure. If you need, you can go for a retreatment, or you can also follow up the patient with an additional secondary filtering surgery or a tube surgery. So we'll have to see with more RCTs where we stand. And once again, I would like to thank my mentor for giving me this opportunity to share the data on micropulse, and which is very promising, and it also falls under the armamentarium of MIGS. Thank you.
Thank you, Prasanna, for your wonderful talk. Before we have the small discussion, anybody has any specific questions to ask? Anybody has questions? Okay, thanks all the speakers for your wonderful talk. Just a few comments on the micropulse. Basically, we had a very good results to begin with the probe type 1, and then we had the second probe. Somehow we didn't see a good results with the second probe. So after a long debate and discussions with the company has again come back with their first probe. So I think it is available. The first probe is again available now. If any of you want to really use it, you can go ahead and use it. So the results are quite good in open angle glaucomas, or even in angle closure glaucomas. There is no specific thing, but we are concentrating on the primary glaucomas. Secondary glaucomas with a lot of distorted eyes, it really may not be very good enough. But then again, when you are using it in the congenital glaucomas or the juvenile glaucomas, one has to be very careful, because there's always going to be a rebound. So we don't see much. Definitely there is going to be a retreatment is really required. And again, in the adult glaucomas, if you really look at the paper, there are at least 2 or 3 times we may have to really do that. So retreatment with the micropulse is definitely a thing that we'll have to remember. So is there any questions? If we don't have anything, then we'll, I think the next session is going to be there. So thank you so much, all of you, for being with us today for this IC. We'll have a small photograph.